Good evening, good evening, good evening.
So, I'm sure करते हैं. I think we are live now.
Oh yes,
And yes.
ठीक है.
So, just good evening, namaskar to all of you from Association of Obstetricians and Gynecologists of Delhi, AOGD. I, Ashok Kumar, welcomes you all on this really hot and humid daily weather. And I would like to have Dr. Asha Jain, madam, to start the proceedings.
Thank you, sir. Thank you so much.
Dr. Asha Jain, ma'am. She is the convener of the today's program, and she is a past president of Raipur Obs and Gynae Society. Ma'am has more than 3 decades of experience in Obs and Gynae. Currently, she is director of SMSA Hospital, Raipur. She is also the president of Raipur Obs and Gynae Society. Her area of interest are fetal medicine, Obs and Gynae ultrasound, critical care, and preventive oncology. Over to you, ma'am.
Thank you so much, Shaheen. Thank you. Next slide, please. We would start the prayer before we take the program further. Namaskar, and let us all join hands in prayer. We can't hear. Shaheen?
Yes, ma'am, I'm doing it.
Please share audio as well.
Yes, ma'am.
Please stop sharing. Shaheen, please stop sharing. Aditya, would you please share?
Yes, madam, give me a minute.
There's no sound.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा असतो मा सद्गमय तमसो मा ज्योतिर्गमय
Now I would like to introduce Dr. Shaheen Bano, Assistant Professor at ABVIMS and Dr. RML Hospital. Ma'am, Dr. Shaheen is the coordinator for this series. Welcome, Dr. Shaheen. Now, with this, I would like to welcome all AOGD members and the dignitaries to this platform and request Dr. C Patel, sir, whose brainchild is this Happy Learning Masterclass. And today we are here to celebrate the 200th Happy Learning Masterclass. It started in October 2020 and this is now 200 that we are celebrating. It is on cesarean section, and I request sir to please give his welcome address.
Thank you, Dr. Asha. It gives me immense pleasure to welcome you all on this 200 episode of Happy Learning Masterclass web series, and it is with AOGD. And for that, I am very much thankful to Dr. Ashok Kumar. He has kindly consented to go with this program with AOGD. I welcome Dr. Neera Agarwal Madam and Dr. Sagar Trivedi, who have kindly consented to be guest and to bless this webinar. I also welcome Dr. Aparna Sharma, who is going to discuss very interesting topic for today's program, understanding Robson's classification and applying it to CS audit. And to chair that very interesting session, I welcome Dr. Jyoti Sachdeva Madam, Dr. Mita Verma Madam, Dr. Jyoti Malik, Dr. Shama Batra Madam, and Dr. Nilanchali Singh Madam. I also welcome one more speaker, Dr. Sonia Naik. She is going to discuss about complication of caesarean section. And to chair that very interesting session, I welcome Dr. Charanjeet Kaur Madam, Dr. Anjela Aneja Madam, Dr. Chandra Mansukhani Madam, Dr. Amrapalli Madam, and Dr. Anjili Nijhara Madam. And today's reverse panel is related to legal issues related to caesarean section, and panelists are going to put their question, their query, and being a moderator, I am going to answer. So for that, I welcome all the learned panelists, Dr. Nidhi Khera Madam, Dr. Sangeeta Gupta Madam, Dr. Nita Misra Madam, Dr. Rinku Sen Gupta Madam, Shahin Bano Madam, and Neha Misra Madam. I also welcome Dr. Asha Jain, convener of this program, and she in this series since long as a convener. I also welcome Dr. Shahin Bano. She has helped me a lot for this program, not only for designing, but up to execution of this program. So thank you, Shahin, for the same, and welcome to this 200th episode of our Happy Learning Masterclass. I also welcome one more coordinator, Dr. Rekha Rajendrakumar. She is president of Bengaluru Society, and she is also since long in this series. So when we started this series in era of COVID-19, I started this series with 2 to 3 friends. I invited them to join. At that time, my aim was to meet our Foxian friends on virtual ground, because in era of COVID, the physical meetings were not possible, and to discuss focus topic, and related to that topic, to discuss legal issues, not to get up into legal problem in that very subject, and if at all, then how to get rid of it was the motto for discussion. And with grace of God, blessings of senior, and help and support from friends, we have continued their journey, and this is our 4th round with all the society of Foxy, and same, this is also 4th round with AOGD, because in past every year we had one program of Happy Learning Masterclass with AOGD. So it gives me immense pleasure to welcome you all the delegates who have joined this program. We are going to discuss related to caesarean section issues today, and it will be a great feast of knowledge, I hope. So without wasting much of your time, welcoming you all. Thank you very much.
Now I would like to introduce Dr. Ashok Kumar sir. He is a director, professor, and head of Department of Obs and Gynae at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital, New Delhi. Sir is Vice Chair elect of ICOG 2024. Sir is also Secretary of ICOG 2021 to 2023. I is the President of Delhi Society of AOGD 2024 to 2025. Sir, I request you to say a few words for the program.
Thank you, Dr. Stein. Today is the 20th episode, 200 episode, and I congratulate Dr. C Patel sir for giving us this opportunity to organize this program in Delhi. And today we have with us our senior patron and past president of AOGD, and she was earlier the head of the department and pioneer in in organizing and forming the Department of Obs and Gynae at UCMS and GTB Hospital, Dr. Neera Agarwal. And we have Dr. Sagar Trivedi also. She is also a learned professor. She is superannuated from Lady Hardinge Medical College. And we have other senior person from AOGD, Dr. Sangeeta Gupta, and she was earlier in ESI Hospital. And we have State Program Officer of Delhi, Dr. Jyoti Sachdeva. She was really concerned, and her motive, one of the motives is to reduce or to work toward rationalizing the cesarean rates in Delhi. And that is why I thought that we should now start thinking of cesarean section, and we should be having this webinar on cesarean section. So this just to increase the awareness among obstetricians and gynecologists, and to discuss the legal issues of cesarean section also. So with these words, I just now request Dr. Neera Agarwal Madam and then Dr. Sagar Trivedi Madam to say a few words. Yeah, Dr. Sahin, you want to add something?
Sir,
No.
now I
After that, first you
okay,
take
so
Dr. Neera
our
and
today's guest of honor are Dr. Neera Agarwal ma'am. She is patron AOGD, and Dr. Sagar Trivedi ma'am. She is a past president of AOGD and Narchi, Delhi. Professor Neera Agarwal ma'am has a clinical and teaching experience of more than 45 years. She is a director and heads of Obs and Gynae at Max Super Specialty Hospital, Patparganj, Delhi. She is an ex-professor and head of department at UCMS Delhi and ex-faculty of Obs and Gynae at AIMS Delhi, and had held the post of past president of AOGD. Ma'am, we are honored to have you with us. We would be grateful if you could say few words of blessings to us. Neera Agarwal ma'am. I think ma'am is busy somewhere. Let's move ahead. Our next guest of honor is
Dr. Sahin, just wait. Dr. Neera is here.
1
only.
minute
Just
दे
wait.
दो ना
Just 1 minute.
Yes, sir.
कभी
Host, please unmute, madam.
Now, can you hear me?
Yes, madam. We can
Yes,
hear
madam.
you.
Yes, madam.
Thank you very much, Dr. Shaheen, for your nice words. And first of all, I think I would like to congratulate Dr. Patel as well as Dr. Asha Jain for organizing this type of serial of webinars on one of the most important topic to every obstetrician, and that is the cesarean section. Although this is the commonest surgical procedure that any obstetrician undertakes, but the problem is that the cesarean section rate is rising day by day. And according to the various census, it has been shown that there has been 2 to 3 times a fold increase in the rate of the cesarean section. And just to quote, according to Government of India, in 2022-23, the rate is about 23%. While in 92-93, it was only 3%. So there has to be certain reasons why the rise is there. Although few documented reason may be just that there is a multi-fetal pregnancies, the chances of IVF with multi-fetal pregnancies, and therefore the cesarean, the previous cesarean is one of the reasons. There are many other reasons, and one of the reason I think I agree with Dr. Patel is the medical legal litigations. So therefore, many times the service organizer, the person who is providing the service or the service provider, as well as the patient, they think that the outcome will be better, and their doctors wants to save their skin and do the cesarean section. I think we have to be, we have to really motivate our that how we can reduce the rate of cesarean section, and therefore with this condition. Although many advances, and therefore, but there are several right. So we all should see that how And I'm sure
Dr. Anjili Nijhara, please unmute your, please
understand
mute
how to
yourself.
save us from the litigations. And this scarcity should.
Dr. Anjali Nijhara, please unmute yourself. Yes.
Today's program is Dr. She's a former director and professor and head of Obstetricians Department of Lady Harding Medical College, New Delhi. She is a former professor and head of Obstetricians Department at NGT University at Gurgaon. She is fellowship at Masterclass Hospital, London,
and North General Hospital, Sheffield, UK. She is a fellow of RCOG and ICOG and had post of past president of AOGD, NARCHI and DGES. She has organized AICOG 2008 and World Congress, NARCHI. Ma'am, we are honored to have you with us. Please say if you could say, it would be grateful for us if you could say a few words of blessings.
Thank you, Dr. Shaheen. And thank you, Dr. Patel and the whole team for having me here as the part of this very important webinar. And Dr. Patel has been doing great service. We've been attending his webinars. He gives us such a good picture of all the difficult and the advancements of the subjects which we are dealing day to day. So I'm very happy we have taken this caesarean section and Robson's classification. Not many people are aware of it, but it is very, very useful for auditing and for reducing the caesarean section rates because, as Dr. Neera Agarwal said, they are rising so much. We need to do something because second caesarean, third caesarean, fourth caesarean, they are really life-threatening conditions. So one should be careful and reduce the caesarean sections as far as possible. And I'm very fascinated by the reverse panel concept. So Dr. Patel will be taking the questions, and when we hear the answers from the expert, I'm sure we are all going to be very, it's going to be very useful for us. So thank you so much for making me a part of this webinar. Thank you, Dr. Patel and the whole team. Thank you.
Thank you, Madam, for sparing time to bless us. Of course, you are always with us in any of our academic activity. Thank you, Madam.
Thank you, ma'am.
Shaheen, just before we proceed further, let's invite Dr. Jyoti Sachdeva to say a few words as she can tell us the viewpoint from the Delhi state point of view.
Okay, so now I would like to request
Dr. Jyoti,
Dr. Jyoti Sachdeva, ma'am, to say a few words.
Thank you so much. First of all, AOGD and President AOGD, Dr. Ashok, for taking this up so promptly. I remember just a month back we were discussing this, and this is seeing the light of the day. So basically, yes, it is the need of the hour, and we did have a ministry's guidelines for some time, and we are following that. So in Delhi, if I quote the figures, it is about 29% on an average of all the delivery points, the caesarean rate. But if we bifurcate into, the average is 34%. If we bifurcate into public and private, it is 29 and 65. So we really need to look at it and yes, audit it and rationalize it. But audit is not something to, keep an eye and have strict regulations. It is to put in some quality interventions and try to rationalize everything. So as far as the journey of caesarean section audit in Delhi is concerned, we started it way back in 22. Under the guidance, we created a core group, and we had the guidance of our senior obstetricians, Dr. Asmita, she supported us as NARCHI president, Dr. Tripathi, who is a great natural delivery promoter. So with that journey, we did start with the scientific way of Robsons, and we went one step ahead of the Government of India guidelines. So we created a denominator for Robsons classification. So we Robsonized all the vaginal deliveries also. So we could make out the absolute ratio of the caesarean sections in a particular Robson group. And many hospitals have been able to reduce their caesarean section rate by looking at where they're in which Robson classification they are having problem. For example, they if VBAC was not happening, then they realized that 5 is having that issue, and so capacity building. For example, some could find that breech vaginal deliveries are not happening, so they did capacity building in that. Some thought that it was. We also put in induction audit so that the unnecessary inductions, reducing that could reduce the cesarean section rate. We put in partogram and the fetal heart monitoring. Some HODs started taking on WhatsApp, and that also reduced the cesarean section rate. So these are various interventions that different hospitals took up once the brainstorming was done through the state level meetings. And another achievement I just want to say, whenever I think we take up some subject, some initiative, it does give byproducts. So what we got as byproduct was, one was that when audit started happening, the processes, the next day, everybody was discussing, and then that report was coming to us. We started, some of the hospitals had a fall in cesarean rate anyway. Then since we made a Google form, and the senior residents, whoever operated was supposed to report that. In that, we introduced some things, and we could, because with cesarean, early breastfeeding is a gap. So we started asking that. To answer that question, I think that practice started, and we could see the results in the HMIS report that early breastfeeding started happening. The anesthetists were requested, and this quality initiative was taken up. Then the postpartum intracesarean IUCD also increased after we instituted this. Of course, there were parallel efforts to increase intracesarean PPIUCD, but these are some byproducts that we received with this. So I think the way forward is that our district program officers are not able to collate data from all private players. And that is where we need support of AOGD, and that is where we feel that convincing everybody that, above 50% after a particular rate, in fact 25, of course the rate will vary as per the level of the facility, but after a particular rate, it just doesn't give benefit to neither mother nor baby. And a lesser known fact, which I would like to highlight, which even pediatricians deny when I talk to them, is that it does have effect on neonatal many parameters, including cognitive parameters. So this the mothers should know, and this everybody should know. So just to avoid any kind of litigation and 100% giving good obstetric outcome, we should not be doing cesarean. And this is just the message I wanted to say. And while we are looking at, producing a good generation, we talk of GDM screening to give a non-diabetic generation. We talk of other things to give anemia prevention to give an intelligent baby. So we should be thinking of avoiding cesareans also to give good intelligent babies to for next generation. And so I think we need to think twice before doing cesarean. Thanks once again, Dr. Ashok, and all the faculty who has brought this forum and platform made available for cesarean audit.
Thank you, Jyoti Madam, for your words about the subject. And it is a matter of very naturally and matter of concern also for we obstetrician people, because even in court of law also, this is one common allegation nowadays. It was unnecessary cesarean section. And many a time, person who has done that cesarean section has to justify in court of law why he went with cesarean section. So now it is a matter of concern, of course. Thank you, madam.
Thank you, ma'am. Now, I would like to introduce Dr. Indu Shavla, ma'am. She is the Vice President of AOGD 2024 to 25 and Professor and Consultant at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital, New Delhi. She is an ex-HOD of Department of Obs and Gynae at RML Hospital. She has her area of interest is endoscopic surgery. Ma'am, I would like to request you to say a few words.
Thanks, Shaheen, for the nice introduction, and thank you very much, Sir Dr. Patel, Dr. Ashok, and Dr. Asha Jain for making me part of this important webinar on cesarean section. And Sir Dr. Patel, I congratulate you on completing 200 episodes of such useful webinars. And I have been part of many, and I've been listening. And all over India, I think you have educated a number of people, especially on medico-legal issues, Caesarean, one of the most commonly performed procedures, as Dr. Neera pointed out, saves a lot of mothers and babies, but it is not without complications and complexities. As any other surgical procedures, it can have complications, but complexities are somehow unique to cesarean section, like right from taking the consent. Why was it done? Was it done too early? Was it done too late? And at the same time, we are worried about its implication in the next pregnancy also. So we want to do it, use the right technique and do it well so that she can withstand the next pregnancy. The uterus can withstand the next pregnancy. And so the topics have been very carefully chosen, and I congratulate you on choosing the topics which are so relevant, all three topics, So I'm looking forward to a very fruitful discussion. Thank you very much for including me.
Thank you.
ma'am.
Thank you, Indu madam, for sparing time to bless the webinar and for your word of wisdom. Thank you, madam.
Thank you, ma'am. Dr. Kamna Datta, ma'am. She is Professor and Secretary of AOGD 2024-25 at RML Hospital, New Delhi. Her area of interest are high-risk pregnancy, oncology, multiple publication in national and international journals. Now let's move into our first session. It's on understanding Robson's classifications and applying it to cesarean section audit. For this session, we have chairpersons as Dr. Jyoti Sachdeva, ma'am. She is currently at she is a state program officer at Maternal Health and Family Planning, Directorate of Family Welfare, Government of NCT of Delhi. Earlier, she was at Maulana Azad Medical College and Lok Nayak Hospital, and at also Pandit Madan Mohan Malviya Hospital as a nodal officer. Her area of interests are reproductive health programs, safe abortion services, quality of care. Ma'am, she is senior consultant obstetrician, gynecologist, and laparoscopic surgeon, and is attached to Mulchan Hospital. Her area of interest are high-risk pregnancy, adolescent problems, menopausal problems, and gynae laparoscopy. Next chairperson is Dr. Jyoti Malik. Ma'am is currently is director at Roots IVF and Fertility Institute, JJIMS. She has held positions of chairperson at Haryana chapter of Indian Society of Assisted Reproduction. She is also secretary of Haryana Association of Registered Obstetrician and Gynaecologists. Ma'am has publications in both international and national journals, and has written chapters in various books of obs and gynae and infertility. And she has been invited as a faculty at more than 200 national and local conferences. And next is Shama Batra. She is senior consultant obs and gynae and medical superintendent at Pardeshi Hospital. She is also the vice president of IMA and former secretary of Indian Medical Association, former co-editor of DMA. Ma'am has conducted many camps on cervical cancer awareness at state level and has participated in many activities like adolescent health, anemia-free India, menstrual health awareness, and many more health-related social activities. Dr. Nilanchali Singh, ma'am. She is Associate Professor at Department of Obs and Gynae, AIMS, New Delhi. She had done clinical fellowship in gynecological oncology at Calgary University, Canada. Gynae Oncology Group Fellow, USA. She is a member of Working Group International Papilloma Virus Society. She has published more than 100 papers in various index journals and editor of book Evidence-Based Management in Obs and Gynecology. She is also editorial board of member of various peer-reviewed journals. Now, I would like to request Dr. Jyoti Sachdeva, ma'am, to introduce our speaker for the session, Dr. Aparna Sharma, ma'am. Jyoti ma'am. I think
Am I
I
audible?
I request hello.
Am I audible? Shine?
Yes, ma'am.
You okay? So
Uh,
it's my pleasure to introduce Dr. Aparna Sharma, who is a professor at All India Institute of Medical Sciences and a very dynamic clinician plus academician, and she contributes to public health, and she's been really instrumental in training our right from ashas to senior people in various topics like anemia. Her special contribution to respectful maternity care is appreciated. So, Dr. Aparna, please, we would like to hear from you about Robson's classification.
Thank you, ma'am, for those kind words. And thank you, Dr. Patel, sir, Dr. Ashok, sir, for having me here. The topic for today is, can I share my screen, please?
Yes, ma'am.
Yes. So, it is actually when we talk about understanding Robsons and applying it to CS audit. So, as we have heard from Dr. Jyoti Sachdeva, Delhi has been working on CS audit for quite some time now. And when we talk about Robsons, I would like to begin by saying that there is a lot of understanding of numbers in it, right? The purpose of computing is insight and not numbers. So essentially, when as I go through my presentation, there will be, a lot of numbers, but as we go on, we need to understand that we have now started saying that it's not the absolute number of cesarean sections. Like I say, okay, my cesarean section rate is say 40%. My cesarean section rate is 50%. But am I able to provide the right care to the right person? That is a more important question to ask rather than saying it in absolute numbers. Now, when we go through this topic, I will divide this into 3 parts: understanding the Robson's classification, interpreting the Robson's classification, and can we intervene based on the Robson's classification. Now, I had the pleasure of attending the workshop which was conducted by Professor Robson, and it was indeed a pleasure to understand why this classification actually came about and what is the best way to implement it. So we will be talking about it in some form of numbers more than what we normally look at. So you might feel that it is a little more on the side of, intense on the number side, but there's a reason to it. So WHO actually proposed that the Robson classification can be a global standard for assessing and monitoring the cesarean rates within the healthcare facility and between facilities. So in today's day and age, if we want to compare our C-section rates, we have to look at Robson's classification. Now, the beauty of the Robson classification is that every woman who's been admitted to give birth in any facility can be classified into one of the 10 groups. And we have to increasingly start saying that, the women come to give birth and not deliver, because delivery is now for the delivery boys. So we need to say that, yes, women who are coming to us to give birth can be classified into any of the 10 groups. So we know when we talk about Robsons, there are these 10 group classifications. And interestingly, we must also look at these pictures. I don't know how many of you have actually looked at these pictures very, very, intensely, because they are very expressive. So the first group is a nulliparous single Catholic who's coming in spontaneous labor. So these 3 marks are marks of labor. So she's a singleton and Catholic who's coming in labor. Now, the second one is one who is nulliparous, single, cephalic, more than 37 weeks, who has been induced. So this particular situation, second one is induction of labor. The third is multiparous in labor. Multiparous always has a child with the lady and she is in labor. The fourth is multiparous and induced, the same configuration as the second one, but yes, multiparous and induced. The fifth one has a previous scar. So the fifth one is more than 37 weeks single Catholic and previous scar. The sixth group is breech. So you can see that the baby has been denoted by a breech, but nulliparous. But when it is a multiparous breech, it becomes group 7. All multiple pregnancies as shown by multiple babies here are group 8, and a transverse lie or an oblique lie becomes group 9. And anyone who is single cephalic preterm becomes group 10. So this is a mutually exclusive group, and all of the women can be classified into these groups. So the parity is nulliparous or a multiparous, previous cesarean, yes or no, onset of labor, spontaneous, induced or no labor, number of fetuses, singleton or multiple, gestational age less than 37, preterm term is more than 37, fetal lie, cephalic, breech and transverse. So these are some of the core variables which have been decided. And of course, there are some subdivisions. Say, for example, within 2 and 4, when you are inducing a patient, whether their patient has been induced for labor or there is a pre-labor cesarean section. So in this particular situation, the cesarean section rate would be 100% because all women have undergone a cesarean section. So 2A, 2B, 4A, 4B, and 5.1 and 5.2 are those with previous cesarean, previous 1 cesarean, and previous 2 or more who will again have a 100% cesarean rate. So we need to see how many of the previous 2 cesarean sections are there because they will anyway have a 100% cesarean rate. So this is a very simple diagram to understand if there is any woman who's come to us to see, is she a multiple pregnancy? If yes, it becomes group 8. If she is a transverse or an oblique lie, she becomes a group 9. If she is a breech, multiparous is 7 or nulliparous breech is group 6. If she is a preterm, she becomes a group 10. So 8, 9, 7, 6, 10 are covered even before, as you start classifying. Now, if all of them are negative, is she a multiparous woman? If yes, is she a previous scar? If she has a previous scar, she becomes 5. If she doesn't have a previous scar and she's a multiparous, then she becomes group 4. And if there is no labor induction, then she becomes group 3. If she's not a multiparous, then it is either 1 or 2. So in the end, you come to the nulliparous, which is either group 1 or group 2. So this flow chart is a very simple way to understand and classify these women. Many algorithms have been built around this flow chart, which are also digital algorithms to figure out which particular Robson's group your woman will fit in. Now, what is important also is that Dr. Jyoti said that we are also calculating the baseline Robsons of every woman. And that is what this Robson classification report table is all about. Because it is not just the woman who's undergoing a cesarean birth needs to be classified in the Robson. Every woman who's birthing in the labor room has to be classified and given a Robson. And it is only then that you can say that, okay, there are so many people. So this is the group size. So this is what we talk about, that if n number of women are in the group number, say 1, nulliparous women of all the women divided by the total number of women who are delivering in the hospital. So that is the proportion of the women who are delivering to be nulliparous. So that all has to be determined. Now, group CS rate is the number of CS in the nulliparous group divided by the total number of women in the group. So this is what we are talking about. So if there are 100 nulliparous women in the group 1, how many women are undergoing cesarean rate? Cesarean. So that is your group CS rate. Again, absolute contribution of cesarean section and relative contribution. What is the meaning? What do I get out of it? Say, for example, if I'm doing 100 cesarean section, who is contributing to maximum of my cesarean rates? In my data, what I see is 40% of my cesarean sections are being contributed by a previous cesarean section. So that is the relative contribution. So this is N of the CS in the group by total N of the CS in the hospital. So if there are total cesarean sections, 40 cesareans are being done for a previous cesarean section. So that is the relative contribution of the group. And all of these numbers become extremely important to understand what is increasing your cesarean rate in your practice or in your setup? Now we will talk about this a bit more, but just going back to the table, this is your Robson's group 1 to 10. Total number of cesarean in group number 1, but total number of women in the group. So why this is important is that every woman who's birthing in the hospital has to be allotted a Robson category. Only then you can calculate this column 3, and the group size percentage will come from there. So this is extremely important that every woman is given a baseline Robsons, and only then we can make some useful interpretation. And from here we come to the next part, which is interpreting Robsons. Now, there is a saying which says that you can't manage what you don't measure. So unless we do a correct measurement, we cannot bring about a change. So Robsons enables us to do 3 types of analysis. One is quality of data. Sometimes, we have huge numbers, right? We have huge data. Are we collecting the data that we are collecting is of good quality? How are we sure that we are not collecting trash? Because we always believe in the GIGO principle, right? So if you put in trash, you will put out trash. So first is assessment of quality. The second is we say, okay, we deal with high risk population. How do I believe that your population has high risk? Can we determine that from Robson's data? Yes, we can determine. And of course, the third and the most commonly used thing out of Robsons and the only used thing is assessment of cesarean section rate. But please remember, unless we do first and second, we cannot come to the third. Now, how do we do first and second? Now, please look at the total number of cesarean and the women delivered in your hospital. So that is the last line of column 2 and 3. So once you have filled the columns, so the total number of cesareans of the column 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and the total number in this group of 1 to 10 should be equal to the total number of cesareans that you have reported for the month and total number of the women that have birthed in the unit. So this is the number 1 to ensure that you do not have a missing data. So that is number 1 that you have to ensure. So that's step number 1, quality check that there are no missing data. Then number 2, if these numbers do not match, then the data is missing or some women have been classified are missing variables. Now, another very important parameter to assess the quality of your data is look at group 9. What is group 9? I have put it for reference here. Group 9 is the transverse lie. Transverse lie in your data or in anybody's data should be less than 1%. That is a population specific data. So if your data entry operator is operating and entering the data, just check your transfer data. If it is more than 1%, then probably you have to check the quality of your data and some breach or transfers have been misqualified as transfers or oblique, and look at other groups which sometimes show that where is the misclassification. So we need to check into the quality of data and whether the data has been entered properly. What is the step 3? Look at the CS rate of group 9. Again, all the transverse lies, oblique lies should be by convention 100%. So this is the interpretation, whether people are able to interpret correctly, people have understood it correctly. Now, if this is not 100%, and if you have written that this has delivered by vaginal, this is less than 100%, then it should be classified as cephalic on breach, and this cannot come in here. So again, whether you have understood the interpretation of this is extremely important. The quality of data is extremely important. So this is the first step, while we assess the quality of data. So 3 steps to assess. So whenever we have the data entry on for the Robson's table, first look at these 3 steps and then move on to the next one, which is the type of obstetric population. If you have any questions or comments, maybe we can put it and take it later. So the next is assessment of the type of obstetric population. Now, this is a very interesting observation. Now, look at the size group 1 and group 2. Now, what is group 1 plus group 2? Group 1 plus group 2 are nulliparous women. Now, nulliparous women normally represents 35 to 42% of the obstetric population of most hospitals. So what is your data showing? Is it showing that group 1 plus group 2 is constituting 35 to 42%? Now, if this is more than that, more than 35 to 42%, then maybe you are dealing with a very high risk group where you have more of infertility, more of IVFs, more of recurrent pregnancy losses, where the nulliparity is extremely high, and then subsequently your cesarean rates are going to be high. So first we have to normalize our population to say that, okay, our cesarean rates are going to be at this rate, and hence we need to be at our population is normal, and hence our cesarean rates have to be normal. So this is step number 1. So in our population, yes, this was between 35 to 40%. So this is around 43%. So that's fine. Now look at the size of group 3 plus 4. Now what is group 3 plus group 4? It is multiparous women. Now, interestingly, multiparous women should represent another 30% of our population. So if it is 30% of the population, this is without previous cesarean. Now, if it is lower, then in that case, it means that probably a lot of previous cesareans are there, so that lesser number of people are non-previous cesarean multiparous. So if this is high risk, so if there is a lot of higher number of multipara, then we say probably either that there is either a low risk multipara or there is a lot of bad obstetric history multipara. But if this is a very low number in this particular thing, we have to look at previous cesarean sections, which is very high. So in our population, if you see, this is not 30%, but our previous cesareans are very high. So it shows that there is a skewed kind of a population where our multiparous women are less, but our previous cesareans are very high. So now if I say our cesarean rates are very high, then they will be high because our multiparous populations are very low. Our multiparous have moved on to being previous cesareans. Now the third point, look at the size of the group 5. Now what was group 5? Group 5, if you look here, is previous cesarean section. Now this is the most difficult group now with increasing cesareans. If you have a previous size, the overall is usually less than 10%. So multiparous, more than 37 weeks, previous cesarean, it has to be less than, in most of the settings, usually less than 10%, right? Now, if it is more than 10%, then that means that there have been a lot of cesarean sections in the past few years, mainly in the groups 1 and 2 overall, and that is what has been happening in the overall country. So if you look at the thing, so our cesarean, this is around 15%, which is quite high. So although it is reflecting the cesarean sections rates, which are already high, so this is, now we are sitting on a population which is multiparous with previous cesarean section, which will further contribute to increasing the cesarean section rate. Now the next point is, another interesting part is, look at the size of 6 plus 7, which is breach. It is a standard thing that in a population, the breach should be between 3 to 4%. So this is how things are made. This is how the population rule is. So if the population is between breach is between 3 to 4%, it is okay. But if the breach is more than 4%, what is the reason? Why is the breach more than 4%? It is because we have more than high rate of preterm deliveries, and we know that if it is preterm, it is more likely to be breach. So if it is more than 4%, look at group 10. Are the preterms high? So when we looked at our data, we found that yes, our breach is more than 4%. So it is around 5% breach. So why? So our preterms is very high. So our preterm is normally should be 5 to 10%. Our preterms is 18.5% because it is a very, very high risk referral population. So we know that the data collection is all right. The quality of data is all right. And our population reflects a very, very high risk population. Now look at the group size of group 8, which is multiples. So it should be between 1.5 to 2%. And if the hospitals runs a high risk referral program or a fertilization program, your population, the percentage will again be higher. And that is what we found, that it is more than 2%, which is around 2.8%. So, and then the last is, what is the size of group 10? In most cases, it should be less than 5 to 10%. And we found that it is around 18.5%. So these are the steps which have been recommended to initially start to say that the data that you're collecting is all right, what is the kind of your population. And another interesting thing that you can look at is what is the ratio of group 1 to group 2. So if you remember, what was group 1? So the group 1 was spontaneous labor versus induced. So what do you expect? The spontaneous should be more than the induced, right? We should have women who are more in spontaneous labor. So the spontaneous labor should be 2, the induced should be 1. But if you have a lower ratio, it means that you have a higher induction rate, which may indicate a high risk population, and hence you can have a higher cesarean rate. So if you are dealing with this kind of a population, again, you might expect a higher cesarean rate. So see what is happening here. So the ratio is less than 2. Again, so our inductions are higher. So we need to look at these ratios to understand what kind of an obstetric population we deal with. So I would recommend, this is all written in the implementation manual for Robsons. If you want, we can share this particular PPT with everybody. But I think it's a status check for all of us to look at the population that we are dealing with, what kind of a population we are, is our data collection correct? So without that, there is no meaning in those numbers. But the third part, of course, is first that we have confirmed that our data is good. Then we talk about the rates. Then we talk about the rates that yes, CS rates in group 1, which is, you look at this picture, which is the spontaneous, cephalic, nulliparous, spontaneous rates are achievable around 10%. And in the CS group 2, it is around 20 to 35%, the induced group. In group 3, which is the multipara spontaneous, it should be around 3%. For multipara induced, it should be less than 15%. For cesarean section, the rate should be 50 to 60%. And for group 8, which is the multiples, the cesarean should be around 60%. And for preterm, the rate should be around 30%. So once we are sure of our populations, once we are sure about our data, this is, so again and again, it is written in the Robsons implementation manual also that these rates are indicative. These rates talk about a situation which is ideal when you have a population which is pertaining to a certain low risk category, certain risk category. So what we have to see is to achieve the ideal outcome. And what we need to understand is, remember 3 categories, category 1, 2, and 5. So the spontaneous nulliparous, induced nulliparous, and the previous cesarean section. These 3 groups normally contribute to 66% of the cesarean sections performed in most of the hospitals. And these are the areas where we need to plan an intervention. So the last part where I would like to talk about is that, okay, we have talked about so many numbers. What are the action points? So there is actually a Palestinian saying which says that you can't fatten a cow by weighing it. So any number of times we talk about the numbers, unless we take some action, we cannot really see the change, or we cannot really bring about a change. So implementation is an important part of measurement. First is measurement. Without measurement, we can't manage. But without managing, we cannot change the measurement. So both of them are important. So stepwise approach to CS audit is appoint one nodal person for data collection, ensure quality data at all times on every month, check that the data quality is good, perform routine data checks to ensure data quality, ensure the data baseline collection percentage CS rates in group 1, 2, and 5. Sorry, this was 5. And then, of course, employ improvement methodology. So we've been talking about it, 4 steps approach to quality improvement. This is something that is very, very easy to understand, easy to take ahead. So identify the problem, analyze the cause, do a PDSA, and then sustain. So if I want to say, I want to reduce the cesarean section rate. Yes, you want to reduce, I want to reduce, everybody wants to reduce the cesarean section rate. But what is the hardcore action that I want to take regarding reducing the C-section rate? So we need to prioritize a problem and make an aim statement. So we realized, all of us know that even Robson tells us that there are 3 main categories in which the cesarean rate is high, which is 1, 2, and 5. Even in our data, what we found is that 40% of our cesareans are because of previous cesarean, and Group 2 is 27%, which is the inductions are 27%. And group 1, of course, is the spontaneous nulliparous, which should not have cesarean section. So these are the 3 groups in which we need to intervene. So we are not, so basically we need to plan. So something like an aim statement. So if we want to make an aim statement, so we want to say, suppose to reduce the C-section rate in Robson's group 1 from 30% to 15% in the next 3 months. So this is how we proceed, targeting one particular Robsons. And even within that Robsons, we need to understand why is that area high. So what are the problems even within Robsons 1? Is it a problem with the human resource, equipment, protocols, training, teamwork? So we need to look into it. Where is the problem? So say, for example, so we are, as a disclaimer, we are saying we are nowhere near the goal. We are trying, we are walking a path. But why is the group rate high in group 1? What is modifiable? So in case of group 1, what are the most common indications for cesarean? So we looked into our data and we found that abnormal CTG, arrest of dilatation are the most common causes for raised cesarean section rate. So what are the possible interventions? So like Dr. Jyoti actually mentioned that CTG abnormalities, can we curtail them? So as she mentioned, we did have a WhatsApp group with everybody, with every CTG abnormality had to be justified. We had to post all the CTGs on the group to discuss why this CTG was taken up on a discussion. So it was a positive discussion to say, okay, what kind of an abnormality? Every CTG had to be classified as Dr. C Bravado on standardized basis of the NICE classification. So this is an ongoing exercise where every CTG has to be classified according to Dr. C Bravado and see whether it was a justified or not, along with the outcome. So this has been going on for a few months now. So we see that the CS for CTG abnormality has been steadily coming down. So this is not to say that the cesarean rates have drastically gone down or this is going to bring about a huge improvement, but these are small measures that we can bring about in the setups to look into the reasons why things are happening. Now, say, for example, induction audit. So what is the rate of inductions in the unit? So every month, the induction audit has to be performed to review the indication for induction. What was the bile acid at which the induction was done for IHCP? Why was the induction done for FGR? Can we do spaced induction for 0, 12, 48 hours? Can we defer the induction? So again, what is the rate of vaginal delivery every month after an induction? How many cesareans are being done for failed induction every month? So first of all, look for data, manage the data, maintain the data, and then plan intervention. So induction audits are something that are happening on a monthly basis. Then the most difficult category, of course, remains the previous cesarean section. So yes, the trial of labor after TOLAC. So we have a mainly plan of care for an uncomplicated pregnancy. So a patient information leaflet on counseling is increased. Also, we insist that the senior most person should counsel for a TOLAC. So there's a drive to increase the TOLAC on increasing the patient awareness. Even during the birth plan classes, we talk about TOLAC so that there is improved acceptance of TOLAC. Also, the use of calculators on what is your percentage success of achieving TOLAC is also encouraged so that, patients are also more motivated on what is your success of achieving TOLAC. Again, acceptance of TOLAC has also been increasing gradually over a period of time that, okay, people are more open to accepting TOLAC from what it was previously. So it is important to maintain trends. It is not like really possible to achieve success overnight. This is a very, very recalcitrant problem. Cesarean section is something that is going to take a long time. But the important thing is to be very, very meticulous about it, understand the cause, work our way through very, very slowly, cautiously, and yet very, very, very in a standardized manner. So to conclude, I would like to say that it is a global problem. It has to be curbed. I think all the senior experts have told us that it has serious adverse effects and unnecessary CS on a baby. And it's a vicious cycle. We do the primary cesarean section, we end up doing the secondary cesarean sections. And then, of course, we end up doing cesarean sections for placenta accretas. So we have to systematically tackle one factor at a time using QI methodology as an effective method. Interventions need to be directed towards trained human resource with the aim to support women during their pregnancy. And we need to have regular training, audits, and dynamic evidence-based protocols, which are extremely essential. So thank you very much.
I think, Dr. Aparna, that was wonderful. That was amazing. And it was very crystal clear how you have defined the various Robsons criteria, the interventions, and how we should go about it. So actually, speaking from my experience, actually, being in a private practice and being into infertility, and also our cesarean rate is quite high. And though we have to keep on sending our monthly data, we have to send it, and we have to, justify the indications why the cesarean is so high. But still, introspecting, I felt we can sort of reduce it. And then once we thought of doing that, when we go on the Robsons Group 1, so we thought many of our patients are asking for cesarean, and because of the pain and all, the attendants are after us, the patient is not able to sort of go through those labor pains. So we thought of introducing the labor analgesia, and epidural analgesia was more frequently used. And then I realized that our section rate definitely came down, maybe by, let's say, 10%. We have yet to sort of go on to the figures, but definitely we could curtail that. So that was one thing. And definitely induction of labor also, we started limiting our, putting a paddle on that particular, whether we can sort of withhold the indication. Then some of the times, another thing was that in the OPD, when we examine a patient and when we sweep and stretch, when the Bishop score is very poor, we just we call that patient frequently, multiple times. And once she is, that latent phase of labor, when she's in the hospital for a very long time, then everybody gets sort of, being in a private setup, we all start getting a little disturbed. So to reduce that time, we thought we should not admit that patient, and we should just let her go, keep her in touch with us, and maybe one can do a NST, send her home. So that was the way we reduced our inductions. And the third thing, the TOLAC that you have suggested, that one can sort of try and reduce, because that is very high these days. And but sometimes in a private practice, I think one has to be very bold, because sometimes even patients who are not in labor, and when we do a cesarean, we see that the scar is just about to give way. And had we given a trial for her, she would have definitely ruptured. So TOLAC is something which I really feel scared trying that, but definitely it is a collective effort, and we all can understand these things better. And this I think initiative by Dr. Jyoti Sachdeva ma'am and Dr. Ashok sir and all of us, it is tremendous. And thanks Dr. C Patel sir for giving me this opportunity. Thank you.
Hello, I just want to say only a few words. Dr. Aparna, it was really very nice, and we have heard many lectures from you in East Delhi also. And my main thing is we have to train our juniors also. See, all obstetrician, I don't think they know about the Robson criteria. They should learn first what is the Robson criteria, and then they should regular practice. They should try to interpret. And when we have done the Manyata program, and that Manyata program in all our staff, labor room staff, all sisters, all the RMOs, and we have trained them regarding the Robson. And we first I was thinking of making the chart. These people should start writing on the chart which group the patient is coming and which group it's not coming. Then later I start making that chart. Now what I have done, I used to tell my juniors to make the diagram कि कौन से group में आया है, and start making the diagram. And very nicely you have shown na कि labor pain का कि there is a sign of the labor pain. Now from last few years, 2 to 3 years, my staff has trained and they are making the diagram and they are showing. And the very important Dr. Jyoti has said, we people are doing the private practice, and it is very difficult for the TOLAC one. And many of the time patient has come and says, please trial for the labor for the previous cesarean. At the end, we are very scared of the litigation part. And if something happened, that is the main part. Otherwise, in the PG level, and many times we have done this thesis on this previous cesarean, and we have conducted many vaginal delivery. But now at this stage, I don't think I can go for this trial part of it. And it's very nice. Aparna, it was very excellent talk. And the Robson is every time whenever you listen, it'll make you learn more and more. Thank you. Thanks to the AOGD and all dignitaries, ma'am, for giving me an opportunity to attend this webinar. Thanks a lot, ma'am.
Hello.
Yes, ma'am, you're audible.
Yes. You know, it's very nice listening to Dr. Aparna, but being a practitioner in a private hospital, so many medical legal litigations are there. And nowadays, in many, you can say, upgraded nursing homes, individual practice is very difficult to implement these things. And, Muhurat cesarean and people, you're so scared that husband not giving consent. And it's not a teamwork. Every person is working as an individual gynecologist, obstetrician. So this criteria is very good. One should try to reduce the rate of C-section, but end thing is litigation. How you're answerable. So one distress, one sign of is little scar tenderness and all, definitely doctors prefer to do whatever people say, but they prefer to do C-section. That's the only thing.
Dr. Patel will answer that question.
Yeah. So how to implement this and justify working at a private institute in a upgraded, you can say premium class of hospitals like Apollo Royal Cradle in Delhi, Rosework, so many blah blah, so many hospitals. In an institute, working in a big hospital with teamwork, it's very good. It sounds good. One should try, but at the end of the day, you are scared of getting caught or held responsible for anything went wrong.
Obstetrician distress is also there.
Yeah, distress is there, but on the top of that, litigation, legal. You know, one case I remember, one doctor, without mentioning the name, when she had a case, the people at DMC and all, they just questioned, patient has IHCP, it was a twin pregnancy, why you operated this patient in a nursing home? Even if the ICU facility is there, even if the tertiary level of care is there, NICU is there, why? You should have sent the patient to a bigger hospital. This is the question mark. If anybody lands up in this trap, has to face this.
I request Dr. Jyoti Sachdeva, ma'am, to give their expert opinion. Dr. Nilanchali, ma'am.
Working in the same institute as Professor Aparna, I know how passionate she is about cesarean audits and all the other perinatal audits. And we have always been, she has been guiding us for a long time. And not just the audits, she is actually making us, the juniors, actually try to reduce the cesarean section rates. So I'm sure ma'am is going to answer to a couple of queries which were raised by the chairpersons about how to reduce the rates in the private setup too, because ma'am has always been working, guiding us. And that was a wonderful presentation, ma'am. I think it's really, really worth spreading the word. Thank you.
Thanks, Nilanchali.
Thank you, Aparna ma'am, for this wonderful presentation. And thank you all the chairpersons for this wonderful talk. Now let's move into our second session. Our second session is on complications of cesarean section. For this, our chairpersons are Dr. Charanjeet Kaur, Dr. Anjela Aneja ma'am, Dr. Chandra Mansukhani ma'am, Dr. Amrapalli ma'am, Dr. Anjili Nijhara ma'am. Dr. Charanjeet Kaur ma'am is a senior consultant and is practicing in South Delhi since 1994. She is attached to Apollo Cradle Hospital, Artemis, Daffodils, and Fortis La Femme. Her area of interest are high-risk pregnancy, infertility, and preventive oncology. Our next chairperson is Dr. Anjela Aneja. Ma'am is certified robotic surgeon from USA. She is Senior Director, Obstetric and Gynecology and MAS Gynae Surgery at Fortis La Femme. She is ex-president of Delhi Gynae Forum, South 2022-2022.
Just leave it and move on.
Okay, ma'am. Her area of interest is robotic gynae surgery. Our next chairperson is Dr. Chandra Mansukhani, ma'am. Ma'am is vice chairperson of Institute of Robson and Gynae. And she is in charge
Dr.
of...
Shine, thank you. I think you can move on. I'm from Gangaram Hospital. Okay. Yeah.
Thank you, ma'am. Next chairperson is Dr. Amrapalli Dikshit, ma'am. She is director and HOD at Department of Ops and Gynae, Miracle Apollo Hospital, Gurgaon. Her area of interest are high-risk ops and adolescent health. Next is Dr. Anjili Nijhara, ma'am. She has done her MBBS from Lady Hardinge Medical College and MD from University of Medical Sciences, New Delhi.
And you can cut it short. Yeah.
Yes,
Thank
ma'am. Ma'am, now I request Dr. Charanjeet Kaur, ma'am, to introduce our speaker for this session. Over to you, ma'am.
Yeah. Am I audible?
Yes, ma'am.
Yeah, you are audible.
Oh, great. So good evening, everybody. And I'm very happy to introduce Dr. Sonia Naik, who's going to tell us about the unending complications of cesarean. And she is basically a very well-awarded gynecologist, a specialist in robotic and gynae endoscopic surgery. She has been awarded as the Inspiring Gynecologist by Economic Times, and she's got a Lifetime Achievement Award for Maternal and Child Health from the Rotary Vocational Award. Plus, she has been the past editor of Fetal Medicine Society. She's been trained at Bradford Infirmary in advanced operative hysteroscopy. So let's welcome Dr. Sonia Naik for a very enlightening session on complications in pregnancy, cesarean complications. Thank you.
Thank you, Dr. Charanjeet. Thank you, Dr. C Patel, for giving me this opportunity. Can I share my screen?
Yes, ma'am.
So, this topic is quite interesting, complications of cesarean section. The only thing is, I might not do great justice because it's difficult to take up complications, etiology, and basically their management, diagnosis and management. So I'm just going to talk about the important perspectives of each of the complications of cesarean section. Now, in 2015, WHO concluded that cesarean section rates higher than 10 to 15% were not associated with maternal and newborn mortality rates reduction. Now, however, there's still a rising tendency in cesarean section rates with a consequent associated morbidity and rising incidence of cesarean section complications. Now, this was an editorial, Cesarean Section 100 Years, the Good, Bad, and the Ugly in the Journal of Perinatology, and which said that attempts to reduce the rate of cesarean deliveries have been largely unsuccessful because of the perceived safety of the operation, as we heard in the last lecture and debated. So, the short-term postpartum benefits, the legal climate, and the maternal request in the absence of indications. Now, if we talk about the complications, let me start with the infections post-cesarean delivery. The CDC and the prevention defines scar infection as an infection occurring within 30 days from the operative procedure in the part of the body where the surgery took place. Now, it divides SSIs into incisional infections and the organ space infections. The incisional can be superficial and the deep, depending upon the facial involvement, the muscle layers. Now, the surgical site infections, now in relation to cesarean delivery, has a distinctive microbial source of pathogens because composed of both skin and the vaginal origin. So remember, surgical site infection in the cesarean section is composed of both skin and vaginal origin. That is what we have to take care as far as the pre-operative preparations are concerned. Staph aureus being the most common organism, though gram-negative bacilli are also involved in this sort of an infection. Now, the skin being the major source of pathogens causing the surgical site infections, what is the skin preparation that we are talking about, and what is the consensus regarding the skin preparation according to different organizations? Now, the different organizations have concluded now that the use of chlorhexidine with alcohol as compared to the povidone iodine and also as per the Cochrane with alcohol for skin antisepsis undergoing cesarean section, and they have compared both these, and then basically the conclusion was that the use of chlorhexidine alcohol resulted in a significantly lower risk of overall surgical site infections as compared to iodine alcohol. Now, what are the other practices to reduce surgical site infections? The management of comorbidities, which is very common in our obstetric patients. So, poorly controlled diabetes, that can impair the host immune response, that can delay reepithelialization. So, basically, manage all the diabetes, renal disease, PIH and all, they should be well managed. What about the hair removal? Now, Cochrane review published in 2012 suggests that hair removal at the time of surgery should be done only to facilitate surgery or for applying adhesive dressings. But shaving the surgical site has been shown to be associated with significantly higher SSIs as compared to clipping. So basically, clipping is advisable than the shaving as a result of microscopic breaks which can happen with shaving. Now, what about vaginal preparations? As we said, that the skin and the vagina both microbes are responsible for SSIs. So now in a Cochrane review, vaginal preparation with povidone iodine solution before CS reduces the rate of risk of post-cesarean endometritis from 7.2 to 3.6% women, especially in those with the ruptured membranes. Now, talking about antibiotic prophylaxis for the reducing the surgical site infections and other infections post-cesarean. Now, the antibiotics should be administered within 6 minutes before the procedure. A single dose of a targeted antibiotic, such as the first generation cephalosporin, is the first line antibiotic of choice. The women who are obese, body mass index more than 30, a higher dose of pre-op antibiotics should be considered. And repeated doses are only reserved for cases of major intraoperative bleeding. Now, what are the other intraoperative practices? As far as surgical personnel are concerned, aseptic and scrub techniques have been shown to reduce incidence of SSI in elective and emergency CS. In perioperative oxygen supplementation, does this have a role? Now, increasing the concentration of oxygen in women undergoing cesarean deliveries does not decrease the rate of SSIs. Now, regarding the surgical techniques reducing the infections, skin incision time, Cochrane review published, they compared basically the coin incision with the fan steel incision, and there was a 65% reduction in the post-op febrile morbidity as compared with the coin incision. Expansion of the uterine incision, which is very interesting, and a meta-analysis has shown that a blunt expansion is better than an incision, and expansion of the lower transverse incision during cesarean delivery found that cephalad caudal direction this way was associated with lower risk of postpartum blood loss, unintended extension, uterine vessel injury, and use of additional stitches. So this is quite interesting. We don't have to pull it this way. We have to pull it cephalad and caudal. So intraoperative measures, placental removal, MRP, manual removal basically is associated with more endometritis and more blood loss. Uterine exteriorization, extra-abdominal compared to intra-abdominal repair was evaluated, and it was found that no significant differences as compared to as far as complication rates are concerned, endometritis, wound infections. Cervical dilatation, does it have a role? It does not affect the post-cesarean infectious morbidity. Closure of the uterine incision, single versus double layer. Again, there's no difference in the post-op febrile morbidity and endometritis between both the techniques. Peritoneum closure, no significant difference as far as endometritis or wound infection is concerned. Intra-abdominal saline irrigation, this was associated with increased intraoperative and post-operative nausea and increased the use of antiemetics without a significant reduction in the infectious morbidity or the endometritis or the wound infection. What about the subcutaneous tissue closure? There has been it should be the hemostasis should be complete rather than stitches, but then this was the consensus that women with subcutaneous thickness more than 2 centimeter closure is always beneficial as far as a decrease in the wound complications are concerned. Now, as far as skin closure is concerned, this was a large meta-analysis which concluded that staples closure is associated with a 2-fold increase in wound infection and separation compared with the subcuticular sutures. And wound dressing for patients with obesity or healing wounds or in which discharge has started, a negative pressure wound therapy, negative pressure wound dressings are available, which are helpful in these women. Now, this was as far as surgical site infections, right from the preoperative pressure preparation to the intraoperative and the postoperative and the antibiotics. Now, what about the urological injuries? So, bladder injury can occur when the peritoneum is open if care is not taken to empty it adequately, or in case of previous surgeries that firmly attach the bladder, when you're pushing the bladder or when you are dissecting the bladder. So it's always preferable to use a forceps and with a fine scissors to the bladder dissection rather than push it with a spongeotum. That's not the preferred thing. And the most frequent sign of urethral injury, they can also happen in cesarean sections if you're not very careful. So therefore, we always say that pull the angle to one side and then take an angle stitch in the uterine musculature. So that is one area where you can, along with the uterine vessels below the uterines, you can actually take the ureter also, ligate the ureter also, or angulate it. So that is the site of the ureteral injury in the cesarean sections. Now, hemorrhage is concerned. As far as hemorrhage is concerned, we all know that postpartum hemorrhage is the most important cause of morbidity and mortality still over the globe, in the globe, as far as cesarean section complications is concerned, and also as a major cause of maternal mortality still. Now, the risk factors being the low insertion of placenta, placenta accreta, placental abruption, atony, uterine atony, multiple pregnancy, then PIH, multiparity, obesity, chorioamnionitis, prolonged labor, poor technique, and prolonged surgical time. So these are the risk factors. And if you look at the risk factors and the reasons for the hemorrhage, the most importantly, placenta accreta, previa, delayed coagulation, the impaired coagulation, these are more significantly involved in the hemorrhage, and wherein the prophylactic measures will not work so much. So you have to be prepared more preoperatively with the multidisciplinary team. Now, so as I said, it is still the largest direct cause of global maternal mortality, contributing to almost 1/5 of all maternal deaths. Uterine atony is the most common cause of PPH, and consequently, the most commonly studied agents are the uterotonics. The most recent WHO recommendations suggest oxytocin as the drug of choice for PPH prophylaxis, although carbetocin was assessed to be probably more superior to oxytocin. Now, coming to the venous thromboembolism, what is the risk of thromboembolism after cesarean section? Now, cesarean section is a risk factor for death from pulmonary embolism. And women delivered by elective cesarean section have at least double the postpartum risk of thromboembolism compared with a vaginal birth. And the risk of thromboembolism after an emergency cesarean section is twice that of an elective cesarean section and 4 times that after a vaginal delivery. Therefore, studies exploring the risk of VTE comparing all cesarean sections with the vaginal birth have found relative risk of 2 to 6.7. Now, these are the risk factors of thromboembolism. The pre-existing, like the thrombophilia, the medical comorbidities, the age, obesity, parity, smoking, varicosities. The obstetrical risk factors being the multiple pregnancy, PIH, previous cesarean, prolonged labor, prolonged rupture of membranes, previous history of PPH. And the newer nuances of the transient risk factors could be like any surgical procedure, hyperemesis, dehydration, and in case she's had OHSS and admission or immobility, or any other current systemic infection, or if she's had a long distance travel. So all women therefore should undergo a documented assessment of the risk factors for the VT in early pregnancy or the pre-pregnancy, and risk assessment can again be repeated intrapartum or postpartum. And women from these all risk factors, if there are more than 2 persisting risk factors, then the low molecular weight heparin should be considered for 10 days after delivery, and more than 3 risk factors at least for 6 weeks after delivery. Now, coming to the most important complication that we are dealing with nowadays, and which involves a lot of preparation as far as multidisciplinary team is concerned, and handling these cases in the tertiary 3 hospitals. So, cesarean section, the placental disorders in subsequent pregnancies, and placenta previa, accreta, vasa previa, they're important causes of bleeding in the second half of pregnancy and labor. Prenatal diagnosis by imaging followed by peripartum management by a multidisciplinary team may help reduce morbidity and mortality. As far as placenta previa is concerned, the cesarean section delivery rate almost becomes 3 times if it is within 1 centimeter of the os. And if we look at the placenta accreta with the presence of placenta previa, so in a case of placenta previa with a second time cesarean section, with the previous cesarean section, it increases the chances of accreta by 11%, and it increases by 70%, that means 7 times if it is a 5th cesarean section. So it progressively increases to almost 7 times if it is a 5th. Now, this placenta accreta syndrome, you can't prevent it. As Aparna pointed out, that the only way that we can deal with these complications is like thoroughly introspect our cesarean section rates, audit our rates, and then improvise where we can. The risk of placenta accreta increases if you have had multiple cesarean sections or a placental disorder like the placenta previa. Now, the rate of placenta accreta spectrum increased from 0.3% in women with a previous cesarean delivery to 6.7%. As I told, 7 times it increases with 5 more cesarean deliveries. So it doesn't stop the placenta accreta spectrum at this point. Cesarean scar pregnancy is also a kind of a placenta accreta spectrum. And the 2 conditions basically may represent a continuum of the same disease, with cesarean scar pregnancy being a diagnosis of the first trimester and placenta accreta spectrum being diagnosed later in pregnancy. Now, like placenta accreta, the rate of cesarean scar pregnancy parallels that of cesarean birth and is expected to rise as the rate of cesarean increases. Now, women who delivered vaginally had an isthmus biometric thickness of 11.6 millimeter compared to women with 3 cesarean sections of only 4.7 millimeters. So it becomes 3 times less. Now, again, a rare complication, but which we come across almost quite frequently also, scar endometriosis, which is perhaps an underestimated complication. So therefore, we come across quite often nowadays. So intraoperative contamination of the surrounding tissue with endometrial cells is a situation that should be taken into account during operations in the pelvis. So very commonly we use the sponges to clean the clean the uterine cavity, and we just, with the same sponge, we might actually clean the rest of the tissues or just keep it over there only. So we have to be careful. If in case you are in the habit of cleaning the cavity with the sponge, clean the cavity, but don't clean the rest of the tissues with the same sponge. And after you have cleaned the cavity, just give it to the sister to put in the trolley. It shouldn't be there on the table, because that is one of the important factors in the pathogenesis of scarred endometriosis. Now, there are certain pediatric consequences too. Like we all know that the stimulation of hypothalamo-pituitary axis leads to an increase in stress hormones contributing to lung maturation. And therefore, the cesarean section increased morbidity in neonates includes respiratory disorders, transient tachypnea, and postpartum hypoglycemia. Now, there are anesthetic complications also, though the overall rate of anesthetic complications during elective cesarean deliveries is very low, and the commonest is intraoperative hypotension. The complications are more for patients with poor ASA grade. The commoner complications can be high spinal, failed intubation, especially those with edema and PIH, failed regional anesthesia, spinal headache, epidural hematoma, and extradural abscess. So therefore, to conclude, evidence regarding risks directly attributable to the cesarean section is scanty. Complications and recovery from cesarean section are dominated by the medical condition of the women preoperatively. Mortality associated with the procedure is anything up to 5 times that for vaginal delivery, with emergency cesarean section almost twice the risk of electives. Previous cesarean section increases the risk of placental problems like accreta and previa and cesarean scar pregnancy. Antibiotic and thromboprophylaxis at the time of cesarean section decreases morbidity in the index pregnancy and can also reasonably be expected to reduce future pregnancy complications. Thank you.
Thank you, Dr. Sonia. It was a wonderful lecture and you nicely covered all the complications of cesarean. But I think we have to include the bladder injury also, especially when there is a rising cesarean rate and 1 and 2 after 1, 2, 3 previous cesarean, there are higher chances of the bladder injury. When you separate the bladder,
there was a slide of urological injuries.
Yeah. So, but it was wonderful lecture and you nicely covered everything. And I know that's the only answer. Just as Dr. Aparna said, we have to reduce the cesarean rate, primary cesarean rate. That is a very, very important for everybody. So thank you very much.
There should not be any difference between a government college or a private college as far as the indications are concerned or complications are concerned. I just want to give one comment here. You know, like paralytic ileus and other things can be reduced if we stop making our patient fasting for 6 to 8 hours. So we can give them a maltose dextrin drink 3 hours, 2 to 3 hours before a cesarean section. This not only improves the motility of the gut, gives the patient good amount of calorie, and improves the insulin resistance also. We should follow the ERAS protocol. Many things Sonia has already discussed. And second thing is do early feeding. Within 3 hours, 3 hours later, after the cesarean, patient can start eating also and motivate her for sham feeding. And the sham feeding is what? Give her a chewing gum 3 times a day. And if she starts immediately after a cesarean section, because under spinal anesthesia, there is no sedation. If she starts, her motility is very good. So chances of paralytic ileus have also gone down with that. Another thing is the fluid. You know, if you see your residents writes down the fluids, 5 wax. You know, 5 wax in a day. There is no need. If once the patient start eating, drinking, there's no need to give a fluid. If you have to give a fluid, calculate as per her body weight. 1 ml per kg body weight. This is what I just want to add on. Rest, Sonia, it was a wonderful talk. And one should never...
Dr. Anjela, I think I actually forgot, and this is a very important point. Very important. Thank you.
I think the more problem in cesarean section in a private setup is all Mahurat cesareans, you know. We also has a lot of previous cesareans. This is because our patient don't want to go for a trial of labor. Even if we try to talk to them, they says, no, I had enough. I was in labor for 24 hours and then you did my cesarean, this and that. But that is also wrong. Then we should say that counseled, documented, document also. That patient refused to lab.
Yeah, but Dr. Anjali, there will be difference in the private and government setups, definitely. But because we don't have the clear-cut guidelines from the even Foxy or the Indian guidelines. So we are uncovered by this thing. You see, in the UK and the American, they have the good guidelines. So they are secure. They are secure. They can be saved because they are following their guidelines. We don't have the clear-cut guidelines.
The guidelines are just guidelines, you know, even they are not protected, but their communication and documentation is far, far better than our.
But up to some, not some extent, rather they are well covered by their protocols and the guidelines. You see, because we don't have clear-cut guidelines. So that is why there is a difference between the government and the private setups. Because in the private...
Madam, we will discuss at the time of a panel all this.
Yeah, definitely. Okay, sir. Yeah, yes. Thank you. Okay.
Thank you.
So I think after hearing all the complications of cesareans, I really feel that there is absolutely no alternative to anticipating the problems that one can have, especially with the increasing previous cesareans, the adhesion problem, the adhesions which can lead to the organ trauma, the urological and the bowel problems. So the preparedness, the planning, and then when you actually...
You are muted, madam. Chandrajeet, madam, you are muted. Please unmute.
Oh. So I was just saying, sorry, that there is absolutely no alternative to anticipating the problems, being very prepared, because we are going to deal with many previous cesareans now. We are going to deal with complications. We have to plan, meticulous planning, and giving complete attention to everything, like the ultrasound report. Where is the placenta? Where is the back of the baby? Where am I going to actually give the incision? And what is the help I need? Is the PAC done? Is the so all of it, I think, becomes very important. The PAC, I think, becomes a very, very important thing. Now, I'll just share something which I faced, a personal thing. So I did a previous cesarean. She was a little obese, and we had all the things in place. The surgery went perfectly normally in spinal, under spinal. In the evening, when I went to see her, I felt she was a little sedated, and when I was talking to her, I found that she was not really replying to me very well. So I said, how long has she been like this? So I asked the sisters and the resident doctor, and they said, ma'am, no, abhi sedation diya hoga, thoda sa aise kar rahi. So maine kaha, nahi, this is not normal. So I sat over there for some time, and I found that she was not behaving normally. And then after an hour or so, she became very aggressive. Finally, to cut it short, it turned out to be a meningitis, and we had to actually do an LP, and she was under 3 antibiotics, everything done according to the book. But these are the problems that one can have, you know. And then, if luckily, she was fine and she recovered very well with the team effort. But these are the things which can really lead you into a real problem. So I think vigilance, being prepared for anything which can go wrong, and quick action, and full documentation, as Dr. Patel always says. Documentation of everything seems to be, I think, the way to go forward. Thank you. Hello, I'm through.
Yes. Yes,
Hello,
sir.
Sir, can I add in one comment, sir?
Yes.
I would like to congratulate Dr. Sonia for her great deliberation. I would also like to say a basic dictum, that the eye sees only what the mind knows. And there, each and every patient is a very different patient, different scenario. And our fullest effort in each and every patient can only bring down the complication rate, which every obstetrician is dedicated to. I would also like to thank Dr. C Patel, sir, for giving us this opportunity and for going on the CMEs, which are covering huge globally he's covering the entire country and giving us a lot of information. I would also like to thank my respected seniors, Dr. Neera Agarwal, madam, Dr. Sagar, madam, Dr. Ashok, sir, and all other esteemed faculty. Thank you.
Shan, you need to unmute. To conclude this session, I would like to thank Sonia ma'am for this wonderful presentation, and I would also thanks all our chairpersons for this wonderful discussion. Moving towards a third session, And for this reverse panel, we have our expert, Dr. MC Patel, sir. Sir is past Vice President of Foxy. Sir is Consultant Obstetrician, Gynecologist and Medical Legal Counselor. Sir is Vice President of Foxy 2018 and is Organizing Secretary of AICOG 2017. Sir is Chairperson Ethics and Medical Legal Committee Foxy 2011 to 2013. Sir, you are welcome.
Yes, I am ready to face any question.
Playing the video.
So audio is not there.
Dr. Shaheen,
Yes.
Can ask Aditya to play it.
Ma'am, I'm connecting, but the number is not connected. Mr. Aditya?
Tech support. Just say tech support, he'll join.
शुभं करोतु कल्याणं आरोग्यं सुखसंपदम्.
Respected seniors and dear colleagues, serving Foxy for years together, on this auspicious day, with folded hands and down head, I seek your guidance, blessings and support to endorse my candidature for the post of Foxy President year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxyian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना. So this was my humble appeal to consider my candidature for post of President Foxy this year, considering my seniority, sincerity, dedication, and easily availability for any Foxyian friends in any given medical legal crisis. I am always there to assist, always there to guide, always there to help. So please vote me. Election would be from 1st August to 10 August, 10 August 5 p.m. So please endorse my candidature, please vote, please support. Thank you very much.
Moving to our session, it's a medical legal issues in cesarean section. And for this session, we have panelists with us, Dr. Nidhikira ma'am. She's head of high-risk pregnancy at BLK Max, New Delhi. Dr. Sangeeta Gupta ma'am, she is executive member of AOGD 2006 to 2021. Dr. Neeta Mishra ma'am, presently she is senior consultant at Apollo Cradle Royal and Sunrise Hospital, Delhi. Dr. Rinku Singh Gupta, she is a senior consultant at Madhukar Rainbow and Rosewalk Hospital, New Delhi. Dr. Shaheen Bano and Dr. Neha Mishra ma'am, both of our assistant professor at RML Hospital, New Delhi. Dr. Nidhikira ma'am, she is the senior director of Gynae and head of high-risk pregnancy at BLK Max, New Delhi. Her area of interest are high-risk pregnancy.
Thank you, Shine. Thank you.
Okay, over to you, ma'am. You can ask
Nidhi,
your question.
welcome.
Thank you, sir. Thank you.
Nidhi ma'am, you can ask your questions.
Okay. So there is a patient, sir. She's progressed well through her first stage, but coming in second stage, now lands up with a deep transverse arrest and it's an high unrotated head. So instrumental vaginal delivery is not possible. Simultaneously, the FHR also starts showing a non-reassuring pattern. So the cesarean section is decided by the obstetrician, but the patient and her attendants do not give consent. So the next logical step is we ask them to sign a refusal, but they are also not willing to give a refusal also. So how should we proceed further in this situation?
This is very common scenario in our day-to-day practice, particularly in private hospital.
Yes.
And they will say that her husband is not available. He is going to come after 1 hour or 2 hours, and then we will discuss with him, and then we will go consent. So when this is the situation, transverse arrest and non-assuring fetal tracing, then we have to explain situation, that is condition of the patient and fetus inside, and importance of cesarean section in time. And we have to record everything in our case paper. Even if they refuse, we have to mention that they will explain everything, but they have refused to give consent. If they are ready to give consent in negative consent, it's fine. If they are not ready, because many times it happens. So in this situation, you can have a signature of any co-patient or any visitor of your hospital that it was explained before us that it is very much needed as far as cesarean section is concerned, but they refuse and they were not ready to give consent. If you can manage this, becomes a abundant caution on your part. Of course, it is not mandatory. If you mention in case paper, it is also enough. But if somebody signs the document, third party, then it becomes a good evidence in court of law. But in this situation, identify that person who is signing the document with all the details, his or her address, mobile number, and all contact details, and explain. If at all it is required, they should be available to give their opinion in a given situation. So if we go like this, it becomes good defense in our favor. Because when patient or patient party do not follow our instruction, it becomes a contributory negligence on part of patient and patient party. And if something goes wrong, then treating doctor is not held responsible.
Just carrying this a little forward, supposing she is going towards an obstructed labor or we are suspecting rupture uterus, then the mother is in danger and then it becomes our prime duty to operate her even against her consent.
Yes.
So then we can go ahead and do that.
So in this situation, when it is dial emergency, whatever you do to save life of patient is always pardoned in court of law. But in this situation, burden of proof will be on your shoulder to prove that it was dial emergency, it was rupture uterus, and it was very much necessary to go with immediate cesarean section to save life of patient. So you will have to prove with all your document. But again, one more question may come on part of prosecution. Why this rupture of uterus occurred? You didn't take proper care to avoid this rupture of uterus. So you should be very readily available to deal with this situation. Because whenever this situation happens in court of law, usually you have to answer 3-4 questions. And very first question is, was it preventable? You cannot say no, because once you know that it was occipito-posterior or any other abnormal presentation and it was deep transverse arrest, it may end up into this type of complication. So you cannot say no, it was not preventable. One more question will come. If it was preventable, then what did you do to prevent it? So your measures to prevent it are taken into consideration. In spite of your care and caution and all the preventive measures, if you couldn't prevent it, then did you diagnose that complication well in time? Say, for example, rupture uterus, just you mentioned. If you have diagnosed well in time, and very important and last question, did you manage that case way in which any prudent gynecologist would have managed? If you can answer all those questions, then you are out of problem.
But if she's heading towards rupture because of a delay in intervention when she lands up in DTA and a consent is not being given, and that time is elapsed and then she's going towards a rupture, that also can be then documented as one of
In
the
this
reasons.
type of situation, if you are working in an institution, then head of the unit, head of the department, head of the institution can give consent on her behalf that it is dial emergency, and it was discussed with me, and it is very much necessary to go with cesarean section with this patient. So we can go, but we should justify our decision, because in court of law, it is very common dictum. Whatever you do, you should be in a position to justify in court of law. If you can justify, you are out of problem.
Thank you, sir.
Yes.
Sir, my question is, suppose we are having delivery or whatever birth in a small nursing home, and it's run by an obstetrician, but at the time of delivery she's not available, and the RMO calls the general surgeon to do the cesarean. So what are the eligibility criteria to do the cesarean section? What are the requisites required in a nursing home to do the cesarean section? And my third question is the availability of blood, whether it should be in hand or it should be arranged and cross-matched.
So as per your first question, can general surgeon perform cesarean section? In one of the cases, Supreme Court has given verdict that even MBBS doctor can do cesarean section. But in this situation, in which circumstances MBBS or general surgeon has gone with cesarean section is taken into consideration. If you are in a remote working place, when you are the only person and gynecologist is not available, and it is acute emergency to go for cesarean section and surgeon is available, surgeon can very well go with cesarean section, because it is emergency situation, and resources where you are working are also taken into consideration. But if it is preferable, if gynecologist available nearby, he should be called and he should perform cesarean section. If gynecologist is not available, and if it is an emergency, then surgeon can also do cesarean section. But again, I would say you will have to justify all this situation by your record. So your record and documentation should be up to date as far as this situation is concerned. One more question was presence of
pediatrician.
Pediatrician. It is always advisable if pediatrician is nearby at the time of delivery. Now, of course, I am doing very less obstetric practice, but when I was in full-fledged obstetric practice, it was my routine in my nursing home at the time of delivery, whether it is normal, whether it is instrumental, whether it is by cesarean section, neonatologist was there in labor room or in OT. So if you can do, it is always better in your favor. It shows your consent to take utmost care of your patient. If you have not facility of neonatologist or pediatrician to keep them present at the time of delivery, and if you are well versed with neonatal resuscitation, etc., you can justify that part also. But it is preferable that pediatrician should be available nearby. As far as blood part is concerned, very recently one case happened and it was RH negative and blood was not ready, cross match was not done, and during cesarean section it was bilateral uterine artery tear and there was severe PPH. Patient was shifted to nearby medical college hospital, but on the way patient expired and case was filed. So in this situation also, if you are dealing with a RH negative patient particularly, and if it is planned cesarean section or planned induction, then you have to send a sample in nearby blood bank and to keep at least 2 units of PCV ready if at all it is required. Of course, you can demand if at all it is required. I quote example of myself only. Just day before, I had cesarean section. Patient was RH negative. She was herself dental surgeon and her husband is pulmonologist. She was B negative. I sent blood sample in nearby blood bank and 2 units were kept ready. Of course, it was not required. Cesarean section went very smoothly. There was no much bleeding, etc. But and we told blood bank that now blood is not required. But it shows our consent to take care of patient. As far as other patient, other than Rh negative patient, if we can send sample in nearby blood bank, it shows our abundant caution. But if we cannot, then are we able to manage blood if at all it is required? If we can say yes, then we can go with any delivery without preparation of blood at the time of admission. Yes, one more question.
Yeah, that is a very difficult means lengthy question. That what are the medico-legal indications and implications of perimortem cesarean section?
So we know when there is a sudden obstetric collapse and we are going for resuscitation. But if we consider perimortem cesarean section, it is a part of resuscitation. Scientifically, we go, if we deliver baby very quickly within 3 to 5 minutes, chances of survival of baby is also there if good gestational age is there, and it will help in resuscitation of that very patient also. I would like to quote example of one of our own Foxian friends from Riva, she's HOD there in Riva Medical College, Dr. Binu Kushwaha. In one of the cases, this situation happened, and she straightway went with perimortem cesarean section. Luckily, baby and mother both were saved. Of course, it is not possible in all the cases, and it becomes very difficult for us to face this situation before relative also. So, and there is no time to go for consent also. So, at the time of preparation of cesarean section, we may call any nearby relative, and during preparation, we can discuss that this is the situation, it is sudden obstetric collapse. If we go with this, there is a little chance of survival. I cannot give guarantee, but this is the only option to go for. If we have discussed like this very quickly, because we have no time, because within 3 to 5 minutes, if you can deliver, then only it will be useful as far as resuscitation part of mother and baby part is concerned. And that way, we have to go with.
And are there any contraindications, or as you rightly said, that consent is not required? So if relatives refuse, but you need not to even ask them that there is, we need to do.
Of course, this is abundant caution. If we can discuss very quickly with one of the relative, it will be in our favor, good in our favor. But if they do not go with consent, then also you can proceed accordingly with peripartum cesarean section.
As a resuscitation protocol.
Yes, whatever you do to save life of patient is always pardoned in court of law. But you will have to prove by your document and records that what happened, how she went into sudden obstetric collapse, what did you do to resuscitate, and ultimately it was the last resort to go for perimortem cesarean section to save life of patient. If you can prove by record, then it is also pardoned, even if result may go against our efforts.
Thank you. Thank you.
Yes.
Nidhi ma'am. Ma'am, your questions.
Yeah. So there is this patient who is undergoing a cesarean section. It's a planned cesarean section. We've had counseling. She has provisionally given a consent for getting a tubal ligation done along with the cesarean section. However, the baby is born tachypnic. Patient is under regional anesthesia, and you and the pediatrician discuss that maybe it is not the right time to go ahead and do a tubal ligation. You talk to the patient under regional anesthesia, decide that you will not go ahead with tubal ligation. It is documented well in the case sheet. Later on, the attendant, her husband, has also explained that ligation has not been done and because of this reason. But 1 year down the line, she gets pregnant, goes through an MTP, and later on that has a perforation and it ends up in a hysterectomy. So now a case is filed against the doctor that I had already signed a document for tubal ligation along with cesarean, but this was not done. Why this was not done?
So even if consent is given, it is not at all necessary for or compulsion for any treating person to go with tubal ligation in this situation. because whatever we do in good faith of patient, it is always pardon in court of law. Just I mentioned prior also. So even if consent is given, but if you think that baby is not well and it is not advisable to go for tubal ligation, we should not and we cannot. One more thing, post-operative counseling is equally important. That we have not done tubal ligation for this reason. It should be well documented in our case paper and in discharge card also. We have to mention that tubal ligation was not done for this reason. And we have to advise contraceptive measures also. After 6 weeks of delivery, usually we advise to go with any contraceptive measures. We have to mention that in discharge card. After all this, if patient doesn't follow our instruction, if they do not go with any contraceptive measures, and if she becomes pregnant, that is up to her. We are not at all held responsible, because once we have explained everything in detail that we have not done tubal ligation, we are not at all at fault if she becomes pregnant, not complying with our advice.
Sir, I just want to know one thing, that can we add here during the consent that irrespective of the condition of the child, suppose she is a 5th gravida and she is not bothered about this child. So can we write that irrespective of the condition of the newborn, my ligation can be, should be done?
So if she has given consent like this,
yeah,
irrespective of outcome of baby,
yeah,
I am ready to go for tubal ligation, it's fine. But if it is not mentioned, then we are the best judge in good faith of patient to take this.
So should we take this, add this line routinely in our consent or not?
At the time of taking tubal ligation, and when she has enough number of children, then we can go like this. But if at all she is interested to, because many times they give conditional consent. If male baby delivers, then only you go for tubal ligation. So in this type of situation, we have to follow consent which is given, because we cannot go beyond the scope of consent given by patient.
Okay, okay.
Shaheen, I think we can take up with the other panelists.
Okay, ma'am.
Yeah.
So
Mita, ma'am.
Yeah. So I would like to talk about this. Okay. My first question is about the timeline between the decision to delivery. That means the patient, she was at home, she started bleeding or had a rupture of membrane, or she was having decreased movements. Then she comes to us after many hours. Once she reaches us and we establish the indication for cesarean, then we are of course rushing because we do not want to waste any more time. Now, these are young patients with another life there, and the chances of litigation are very high if there's any problem that occurs. And that actually puts us in a jiffy and we are on our toes and the team is running around. Whatever time she has wasted at home is different. Once she reaches us, she's our responsibility. Now, the point is that if a patient comes with something like cord prolapse or antepartum hemorrhage, we all know it has to be done as fast as possible, maximum within half an hour. And in some indications, the limits are between up to 60 minutes and even 90 minutes. So how do we go about this timeline? Because sometimes patient has an indication, but she has eaten. Sometimes a relative has just left the room and gone away and not traceable. For the consent, we do face all this day in and day out. And of course, the OT being busy. So how do we do our best to not get into these litigations?
So naturally on admission, we start with history. What is the complaint? If she gives complaint that pain in abdomen or labor pain, naturally our next question will be since how long? If she gives history that since 6 hours or 7 hours or whichever, so we will note that patient had pain in abdomen or labor pain since 6 hours. If any other complaint, bleeding PV or leaking or any other complaint, we will mention. If patient reports late, we are not responsible for that. But once we accept patient to treat, I will discuss little other part also. So whenever we accept any patient to treat, it becomes a contract or legal contract, I would say, implied contract between patient and ourselves. We offer our expert services, patient pays for that, or patient promises to pay. So it becomes a legal contract. So our legal duty starts from that point of time when we accept patient to treat. So, and if at all there is breach of that legal duty due to carelessness on our part taking treatment in that very given situation, that will be one more ingredients for negligence. So existence of legal duty, breach of that legal duty, and third ingredient, damage suffered by patient. So if patient has suffered any damage, this is third ingredient for negligence. And very important part, that is fourth ingredient, action of doctor should be direct and proximate cause of that damage. So whatever damage patient suffers, is it direct and proximate action on part of doctor is taken into consideration. Now in this situation, when patient is reported late after 5 or 6 hours or whichever time, and if condition is already worsen or bad, we have to explain everything on admission to the patient and patient party. This is the situation. Even if we go with cesarean section immediately, then also 100% guarantee cannot be given. We have to explain everything. You have reported late. It should also be mentioned in case paper, and it should be also explained to the patient and patient relative. If it is well documented, and if we go with delivery or cesarean section, whichever, and if something goes wrong, it becomes good defense in our favor, because it becomes contributory negligence on part of patient. Because during antenatal visit, if we have advised, then if there is pain, if there is bleeding, if there is leaking or any other complaint, please visit hospital immediately. So in last trimester or so, we have to mention this 2 to 3 lines in our antenatal checkup. And if patient doesn't follow, then it becomes good defense in our favor.
My second question is on the gauze and sponges. So what happens is that nowadays we have all become so particular that when we come in, we normally see to it that the gauze pieces and all, they are counted. Many of us don't even allow the gauze to be kept on the trolley. We just do with the sponges.
Yes.
Many of us even avoid the gut packing not to put anything inside. And after the sister has done the count while abdominal closure and the second skin count, yet we go and count ourselves. So most of us are taking all these precautions. In spite of that, I was surprised to find while going through the cases that a large number of foreign body findings were reported. So what is your take on that? Of course, besides being careful, because there were some cases I read, there were acquittals of doctors, and in some cases they had to pay up. So your guidance on this?
So this is very difficult situation for any doctor to face in court of law, because once you have left mop or gauze or cotton or any instrument inside, it becomes a case of res ipsa loquitur. It is maxim in law that evidence per se or evidence speaks itself. So patient will have to prove only surgery was done, and after surgery, sonography or MRI or any other report proves that there is something inside and it was left at the time of that very surgery. It is enough to prove against any doctor. So it is very difficult cases to face in court of law. But there are few cases also in which result could be in favor of doctor also. I would like to quote 2 cases in which I appeared on behalf of doctor. In both of the cases, we won the case. Decision was in favor of doctor. First case was like this. It was case of infertility conceived by treatment by that very gynecologist, and unlucky on part of patient. At 26 or 28 weeks of pregnancy, she developed non-immune hydrops fetalis. So cesarean section or hysterectomy, whatever we say, was planned and it was done. But at the time there was little bleeding, so mop was kept at that time. And during that mop, that gynecology, so that there was addition of right tube with appendix. So he thought to go for adenolysis because it was case of infertility in past also. So he thought that it would be beneficial to the patient. So he went with that adenolysis and appendicectomy. And at that time, he forgot that mop was kept to control bleeding. And in quick hurry, he closed the abdomen. Everything was fine. Post-operatively, patient was discharged. After 1 month, patient came with little discomfort in abdomen. On sonography finding, he could found that there is something inside. So he explained to the patient, there is some small swelling and we have to remove 2 stitches only and to remove that very part. He didn't say that there is mop inside. Everything was planned. Patient was admitted. Very next day, surgery was planned. But in that very town, one anesthesiologist was known to that patient. Anesthesiologist called that gynecologist. Can I attend surgery which is planned tomorrow morning at your hospital? She is known to me. So gynecologist thought that if he allows that very person and he is known to that patient, then it will be little difficult one to face the situation. So he told that I have given call to another anesthesiologist. He insists, I do not want to come as a anesthesiologist, but just as a relative. But that gynecologist refused. So when gynecologist left the hospital, anesthesiologist went to that very hospital. He took that patient to another nursing home. He went to surgeon, and very next day surgery was done. Mop was collected, and they had a photographs, and they preserved that very mop. Case was filed, and advocate was defending that gynecologist. I entered in very last stage at the time of argument only. But when surgical note was put before me, I could see that note which was given by a surgeon, and this note was contradictory. So I argued with that surgeon because there were so many rewriting in that very note. And one part, surgeon went with only one injection of amikacin. So I asked him that what is the half-life of amikacin? So he told that 8 to 12 hours. Then should we repeat this injection? Because there is no alternative oral to the amikacin. So he said yes, but you didn't give. So that way we argue. And in court, that surgical note was proved hostile. And National Commission was kind enough to give benefit of doubt to that very doctor, and case was decided in favor of doctor. But it is exception. It is exception. In every case, it doesn't happen. And one second case which happened just 1 year back, it was known case of sickle cell anemia. And in middle of the night, cesarean section was done, and she forgot mop inside. Very next day, patient was comfortable, but day after, she had little distension, and she called surgeon for opinion. It was small town. Surgeon advised to go for MRI, CT scan, etc. to confirm the diagnosis. But there was no facility. So patient was transferred to Baroda Medical College. They went with conservative treatment for 24 hours. And ultimately, they went with laparotomy, and mop was removed from abdomen. But in this situation, of case was filed, in this situation also, note of surgeon, note of pathologist, and note of forensic department person were different. Surgeon put that it was mop. Pathologist mentioned that it was piece of cotton only. And in a forensic note, it was something different. So benefit of doubt was given to that doctor also in that. And we could prove, because at the time of laparotomy at Baroda Medical College, straightway from operation theater, patient had to be shifted in ICU on ventilator. Something went wrong in that very surgery also. So we could argue in court of law, patient didn't die of this mop which was left inside, but it could be sickle cell crisis. And court was convinced, and doctor was saved in this case also. But both of these cases, of course, I was lucky, I was defending both of them, but these are exception only. Otherwise, to leave mop or any instrument or any gauze or any cotton inside becomes very difficult to face in court of.
The request for cesarean sections, my last question. Yes. The request for cesarean sections are increasing in our country a lot for primary cesarean also in absence of any obstetric and medical indication. So this cesarean delivery request by maternal request, there are quite some guidelines in many countries where they approve of it after appropriate information to the patient. So we have the ISS Italian guidelines, the NICE guidelines, the RAN-COZ for New Zealand and Australia. They advocate it, but after appropriate information. Of course, Canadian guidelines, they reject it and they say we should perform it only for standard indications for cesarean. One is I could not find guidelines per se for CDMR by FOXI. Though we did talk of explaining to the patient properly about the indication why we are doing a cesarean, but CDMR per se I could not find. So what is your take in medico-legal perspective for this requesting, giving into patient's request? For
as far as cesarean on demand.
One second, sir. Sir, before you answer, just wanted to point out that we are in last 20 to 25 minutes of the program. It's roughly 8:15 now.
Okay. So we will have to be a little hurry. So as far as this cesarean on demand, so on particular day, particular date, particular time they are demanding. But in this, there is one argument. If patient is major, if patient is mentally sound, patient can take decision. One thing. And they take based of Article 21, life and liberty. And in so many of the cases at the time of argument, court has also given that patient may have right to take decision like this. Of course, we have to explain if it is not indicated, if there is no valid indication, we can explain. But in spite of all this, if patient demands, we can honor her request. Legally, we are not held responsible anyway.
And on the discharge, we can write that cesarean was done on patient's request.
Yes. We have to mention if there is no indication for cesarean section, only demand, then we have to mention.
A very similar situation also comes when she is in labor. She started taking labor pains, but midway through, she does not want to take labor pains and there also opts for a cesarean. So there again, the argument is given that it is her choice to opt for the mode of delivery, having understood the pros and cons of both the situations.
If patient gives consent for cesarean section when she is major and she is mentally sound, we can very well go with cesarean section, nothing to worry. But we have to explain that very situation and probable outcome in that situation, because many times patient gives consent very late. As just you mentioned that in the middle of the trial of labor, and if baby is with asphyxia or so, and we have to rush to cesarean section, we cannot give guarantee about result. So we have to explain everything and then we can go with cesarean section. But I would like to mention, because many times argument on part of prosecution would be when she gave consent, she was in agony of pain, labor pain, and consent, she was not with sound mind. So consent given at that point of time cannot be considered valid consent in eye of law. So in this situation, we could be in trouble. So better we should take consent on admission only. And I would like to mention, if you have to simply visit FOXI website, on FOXI website, FOXI uniform consent are available. We 3 medico-legal experts have prepared consent. Dr. Dilip Balke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. C Patel from Ahmedabad. We have prepared 30 different consent. And in those very consent for cesarean section is also there. And consent for normal vaginal birth is also there. And in both the consent we have mentioned everything. So if time permits and if I am allowed to share my screen, I can show how we have prepared that consent. Can I be allowed to share my screen? Shine?
Sir, you should have access.
I'll be very quick. So this is the same consent just I mentioned, and it is available on Foxy website. We have prepared those consent in two parts. Part one is information and part two is undertaking. And we have prepared those consent with base of famous case of Samira Kohli versus Dr. Prabha Manchanda, which was decided in Supreme Court in 2008. And in that very case, Supreme Court came up with guideline. What is the ideal consent in Indian context? And what we should explain at the time of taking consent. Say, for example, name of procedure, C section, meaning we have simply mentioned to cut open abdomen, to cut open uterus and to deliver baby. That way we have mentioned all the indication we have mentioned. We have to take that very indication whichever fit in our patient, or you can mention one more indication if it is there. So we have to go with like this. And we have mentioned what is elective cesarean section, what is emergency cesarean section. We have mentioned that also. Description of procedure, how cesarean section is done. Benefit of procedure, how it will be benefit to the baby and to the mother. We have explained that also. Alternative, if patient is not ready to give consent for cesarean section, then we have mentioned alternative also. Consequences of refusal of procedure. If patient is not giving consent for cesarean section, then which are the consequences of refusal? We have mentioned that also. And outline substantial risk we have mentioned. Say, for example, risk of anesthesia, risk of excessive bleeding or blood accumulation, risk of infection, possibility of infection, injury to surrounding structure like urinary bladder or vessels or anything. Say, for example, if you are dealing with a case of previous 2 or 3 cesarean section, it is all likely that bladder could be injured, or at the time of opening abdomen, we may injure bowel also. So we have mentioned that also. Every individual has a different way to cope up. So we have mentioned possibility of hernia formation in future, scar pregnancy in future. We have mentioned everything. Very rare condition, that is allergic reaction to drug, also we have mentioned. And future consequences. So possibility of adherent placenta, scar ectopic pregnancy in future we have mentioned. And neonatal backup. Also we have mentioned that neonatal morbidity and need of NICU should also be explained, and it is also explained. Part 2 is undertaking. So whatever we have explained in part 2, patient will go in undertaking in part 2. But very important part I have to mention that we have mentioned like this. I understand that during course of surgery, doctor may find other unanticipated, unhealthy condition that may need specific action, procedure, surgery, and anesthesia. If doctor feels that it will be beneficial to treat such condition while performing proposed surgery, and if I am not in mental or physical capacity to give consent, doctor may take necessary decision after discussing with Mr. or Mrs. who is waiting outside operation theatre. I authorize above mentioned person to give proxy consent on my behalf. If patient has given consent like this, we can discuss with that very relative, and if relative give consent, we can proceed accordingly. But we have mentioned this also in one para. In order to save life, it may even be necessary to do additional surgery or procedure or prolonged anesthesia, which are beyond the scope of consent given by me. I authorize doctor to take such decision if need be. If patient has given consent like this, then without discussing with anybody, we can proceed accordingly. So we have prepared this consent. You can download this consent and you can use in your day-to-day practice. Because to explain in prior is very much important. If at all we are going to go for tubal ligation, we have to explain. If we are going to go for cesarean with myomectomy, then also we have to take consent prior, and then we can go. Of course, if myoma is on the way to deliver baby, and if you have not taken consent for myomectomy, we can very well go with myomectomy to deliver baby. But if it is not on the way, then we have to take consent prior also. So if we have taken prior consent with all these explanation, then it becomes good defense in our favor. And at the end, signature or thumb impression of patient, 2 witnesses, one in favor of patient, one in favor of hospital, and signature of doctor is also very much must on consent paper, because when we treat patient, it becomes a contract or implied contract between patient and ourselves. And under Indian Contract Act, unless all the party involved in the contract signs the document is not complete. So we have to give signature of doctor on consent paper. So with this, coming to that very point. So whatever we explain at the time of admission, it is always better because when we take consent at the time in the middle of labor for any part, say for example instrumental delivery or for cesarean section, it can be challenged that patient was in agony of pain and it cannot be considered as a valid consent. We have prepared consent for normal vaginal birth also. In that very consent, we have mentioned that there is a possibility to go with instrumental delivery also, with operative delivery also. So we have mentioned that also. And if patient has given consent, that say for example, if you are going for trial of labor, and if we end up into complete perineal tear and we have to naturally suture, if we have taken consent prior at the time of taking consent for normal vaginal birth, and if we have mentioned that of course there is rare possibility, but it can happen, 3rd degree perineal tear or complete perineal tear, and in this situation I give my consent to proceed accordingly with the condition to my doctor, then we can proceed accordingly. So consent is very important part in our day-to-day practice, particularly in era of CPA. Yes, next.
Dr. Shaheen?
Yes, ma'am. I'm just sharing my screen, ma'am.
Shaheen, we can ask the other panelists to ask questions since we are running short of time.
Yes, ma'am. Dr. Rinku Sengupta ma'am had left the session because of some emergency. On behalf of her, I would like to ask only one question to you, sir. If a mother is in 2nd stage of labor in a well-equipped tertiary care center and is very uncomfortable with the CTG bed and refuses it, and we monitor FHR with hand Doppler and document the reading of the hand Doppler or stethoscope with the pen on the file, and there is no trace available in that period, will that hold valid in the court?
So in this situation, we have to explain importance of CTG tracing. Naturally, we plan our treatment further with CTG tracing. If she is not comfortable, we have to explain. And if she gives consent that I am ready to remove this CTG belt, and I had been explained importance of CTG tracing, and I am going to take all the risk related to that after removing this CTG tracing, then we are saved in court of law. But in this situation, with our hand Doppler, with our stethoscope, or with any other measures, we have to monitor that labor very closely.
So all centers may also not have the option of a CTG with them. So there again, they will be documenting it only with,
with our hand Doppler, stethoscope, and progress of labor, we have to mention everything. And if we have mentioned everything and if we have treated that very patient as per standard medical norms, we are safe.
Just wanted to add only one point here, that even in the setups where CTG is being done and we are keeping it as a record, the ink usually fades after some time. So it would be a good practice that we take a photocopy of that and attach that in the file.
Yes, we can. This is abundant caution. Whatever we do to justify our action, to prove our action means our treatment management part, it is always better in court of law. It is in our favor.
So is it mandatory to take a vaginal delivery consent?
Naturally, yes. Because we never know. She may end up into instrumental delivery. She may end up into cesarean section. She may end up into any complications. Say, for example, big vulval hematoma, and we have to go with this to drain that very hematoma under anesthesia. Any paraurethral tear or any other cervical tear, say, for example. So we never know how she will progress. So it is always advisable. It is always better to go with consent for normal vaginal birth also. It is available on Foxy website. We have taken many pain to prepare all those consent. You have to simply download and use in your day-to-day practice.
Neha ma'am.
Good evening, sir. I'll be quickly asking a case. So a G2P1L1 previous cesarean patient at 37 plus 5 weeks of pregnancy underwent into labor, and she complains of a spontaneous rupture of membranes. On examination, the lighter was found to be blood stained and FHR was 60 beats per minute. It was between 50 to 60 and was confirmed on USG also. It was bradycardia. She was prepared for cesarean section. Meanwhile, the OT was busy. Another case was going on for fetal distress and uterine layer was being closed. Relatives are counseled, patient is counseled, explaining all the maternal and fetal risks. And baby is delivered after 26 minutes of the decision. The decision to delivery interval here is 26 minutes. Baby does not cry immediately at the birth. After resuscitation, baby cries and developed hypoxic ischemic encephalopathy. So does this case carry any medico-legal implications? And what could be done better in this case?
So in any type of this type of cases, court consider in which situation you are working and you were working. So in that very situation, cesarean section was planned, consent was given, but OT was not available. So this is not fault on part of doctor. And in this situation, if we can explain that this was the situation and whenever OT was available, we straightway went with cesarean section very quickly. You are saved in court because ultimate result are not taken into consideration in court always, but your efforts to save life of patient, to take utmost care of patient are taken into consideration.
And so one more case. So a placenta previa was being managed conservatively in the ward at 36 weeks. At 2 a.m. in the night, she undergoes into labor and started bleeding heavily. There was no attendant available. Patient gives consent of cesarean section, but says to wait for her husband, which is at 1 hour of the distance. And her vitals are normal. FHR is also normal, but patient is bleeding continuously. So what should be done in this situation? Patient gives consent, but asks to wait for the husband.
At the time of consent, and see, this is conditional consent, that after my husband comes, you may go with cesarean section. So at that point of time, what is the condition of patient and fetus? We have to document in case paper and we have to take signature of patient. I have given consent for cesarean section, but I have requested to wait for my husband to come. And when her husband comes after 1 hour or after 2 hours or whichever time, again we have to mention condition of patient and baby and explain to the patient and her husband also. At that point of time, condition was this. Now condition is this. And we are going to go for cesarean section. These are the likely outcome as far as mother part is concerned and baby part is concerned. And again, signature of patient and husband should be taken. And then we can proceed accordingly. We are safe.
As the last one off-topic question, so if we are working in a public sector, government sector, we are protected by institution and the HODs and all the seniors. So even if you're working in the public sector, do we need to take personal indemnity insurance?
Yes. Because in one of the cases which happened in city of Ahmedabad only, even one of the resident doctor was punished with awarding rupees 1 lakh compensation to the patient. So we are not safe that way. And in any institution, even one patient is charged, even 1 rupee. All the patients, even if they are treated totally free of cost, they are consumer. So they can sue. If all the patients are being treated totally free of cost, then those patients are not consumer and they cannot go for compensation in Consumer Protection Act court. But they may sue in civil court, in civil suit. So we are not safe in era of CPA and civil suit. So it is always better to go with personal indemnity insurance.
Thank you, sir. Thank you so much.
So can I ask one more question?
Yes.
In a smaller setup or a nursing home kind of a setup, what are the basic essentials that they can conduct a delivery? Supposing they do not have a blood bank, they do not have a blood storage also. and the distances and things are there, then it's run by a gynecologist. So you don't have a surgeon in-house or an in-house pediatrician or a urologist.
Yes, sir, there is no law, there is no guideline where you can deliver patient or when you can deliver patient with high risk pregnancy. But at the time of deciding this type of cases, usually few questions are asked on part of court. One, where you are planning or where you deliver that very patient, are you able to manage for emergency investigation? Not in your hospital, but nearby? Yes or no? Are you able to manage for blood in nearby blood bank? Yes or no? Are you able to involve any super specialist or any consultant or other colleague well in time nearby? If you can answer yes, it's fine. Are you able to go with straightway emergency C section at your setup where you have admitted the patient? Have you backup NICU or baby care at your place or nearby? If you can answer all those questions, then you can deliver baby or you can go with C section at any place.
Thank you, sir, for this
Thank you
one.
so much.
Thank you so much, sir.
So is there any question or we should conclude? So before we conclude, I would like to thank again AOGD and Dr. Ashok Kumar and Kamna Madam and Indu Madam in particular for giving us chance to do our Happy Learning Masterclass 200th episode with AOGD. When I talked to Dr. Ashok Kumar that we are approaching our 200 episode, at that time I was doing 198 or so. He straightway told that 200th episode will be with us only. And I am lucky enough that we are here to complete our 200th episode with Happy Learning Masterclass. So to conclude, again, my humble appeal to vote for me. You have seen hardcore obstetrician as a president of FOXY. You have seen hardcore endoscopic surgeon as a president of FOXY. You have seen hardcore IVF specialist as a president of FOXY. And now it is turn of hardcore medical legal expert as a president of FOXY. So please consider that I am always on call away for any assistant to any FOXian friends. Thank you very much. And one more request on part of Dr. Asha Jain also. Only 1 minute, Ashok, only 1 minute.
Yeah.
On behalf of Dr. Asha Jain, she is contesting for post of chairperson, Food, Drug and Medico-Surgical Equipment Committee. So her election would be from 16th August to 25th August. And in this society votes and some special persons who are eligible to vote will vote. So whomsoever you know who are voters for her, please tell to vote in the favor of Dr. Asha Jain also. Thank you. Yes, Ashok Kumar.
Yes, sir. Thank you very much for a very wonderful, happy learning series of webinars. And we had the privilege of hosting 200th episode. And so thank you very much, sir. We wish you best of luck and hope to see you in Delhi 2026.
Yes.
So, and
we install as a President FOXy.
Yes, sir. Thank you, sir. Thank you so much.
Thank you.
Thank you, Ashok, sir. I'm in the train, so I don't know how well you can hear me, but thank you.
Yes, you are audible.
So thank you to all AOJD post holders and also all the audience. Thank you, MC Patel, sir, for having me in on this 200th episode. And thank you all the delegates who have been listening. Thank you, tech support. Thank you, Shaheen, for doing all the hard work. Thank you so much. We meet again in the next program. And thank you for being with us in the 200. Namaskar, Shubh Ratri. Good night.
Thank you, madam. Thank you.
So thanks to Shaheen also. Yes,
Thank
for
you, sir.
special effort. Yes.
Now, sir, my last request, I request everyone to participate and register in the upcoming AOGD, and the subset submission is now open online. Please register for the AOGD 2024, sir.
Thank you. Thank you. Thank you.
Thank you, sir.
Thank you. So should we conclude, Ashok Kumar?
Yes, sir. Thank you, sir.
Thank you.
Good night, sir. Namaskar.
Namaskar. Namaskar. Yes, we can conclude.